Welcome to the Northeast Kingdom Voice. I'm your host, Scott Wheeler. Today's guests are Catherine Matheson, a psychiatric nurse practitioner, and Dr. Leslie Lockridge, an oncologist and adult medicine practitioner, correct?
Yeah, that's right, internal medicine.
Right, internal medicine. What is internal medicine?
Internal medicine is typically thought of as practice of general medicine for adults and concentration in adult medical problems, exclusion of the pediatric population, and perinatal medicine, and is probably most commonly thought of as primary care.
Right. And an oncologist, you treat people with cancer.
That's right, blood diseases and cancer.
Right. So you're basically, when it comes to oncology, nobody really wants to go and have to go see an oncologist because your day is probably going to be rained upon.
By the time that a patient gets to an oncologist, they usually have their diagnosis already in this day and age. And frequently, I am giving people better news than what they expected.
Right.
Nobody wants to have to see an oncologist, but things have changed quite a lot in the last couple of decades. And we are now able to give people a lot of good news and good options for care that we couldn't give them before.
Right. And now, but you are the star of the show, and you work for Dr. Lockridge, and you're not a doctor yet, correct?
I'm a nurse practitioner. I'm working on my doctorate for another
But
subject.
not all nurse practitioners or physician assistants, they don't all want to become doctors, but you do.
Well, I want to be a nurse practitioner. That's a model that is nursing, basically.
Right.
There's physician's assistants, which is similar, but a different model. I started out as a nurse, and then continued my education until I got prescribing privileges. So,
But you are working towards your doctorate. You were
in the
telling me.
humanities, so that's a left turn. So,
Right.
nothing to do with nursing, but.
So, how did you come about working for Dr. Lockridge?
Well, we were both working up at the correctional facility. I still work there. And we just would chat about what was going on in the community, the lack of services, and the more I got to know Les, I realized our philosophies were similar about patient care and the patient coming first. And so eventually he asked me if I'd want to come on board.
Right. Is there a true need for your services?
Yes, definitely.
So we're not all like totally with it around here?
Well, I think the issue is there's a lot of people and not a lot of practitioners who do what I do, or psychiatrists. There's very few.
Right, yeah, because psychiatrists are really, they're difficult to come by.
Yes, yep.
It's a very specific subspecialty, and one that in particular we're lacking here.
Right.
When the hospital did away with their psychiatry department, there was a huge void that was left. And I can't necessarily speak for all the available psychiatric surgeons, psychiatric services in the region, but for the ones that we are aware of, there was an 11 to 12 month waiting period, and I was acquiring patients that had suicidal episodes every month. Obviously, that's a need that had to be addressed.
But you're a doctor. Doesn't that mean you're a doctor of everything? Like, what about psychiatric what about the psychiatric needs? Like, of course, if I went in with, some physical health ailment, you can help me.
Mm-hmm.
But on the other hand, how about if I went in with some kind of psychiatric issue? What would you do without her or anybody else?
Well, the truth is, we all do a little bit of psychiatry up here, just because of the nature of healthcare in the region. To some degree, every internist will do some degree of, some amount of psychiatry in their career. They will take care of some psychiatric needs for their patients. But psychiatry and really all specialties in medicine now have so much information at their disposal, and there is so much knowledge, so much experience available, that it's really a disservice to the patient to not have someone that concentrates in that particular field look at their case. General practitioners can do lots of things well, there's no question about that, but I think we would all agree that most psychiatric cases are better handled by a specialist.
Do you agree?
Yes, I do. Yeah.
And when did you start at Dr. Lockridge's practice?
About 3 weeks ago.
Mm-hmm.
Not too long.
So you have an interesting perspective, because if I recall right, you worked at the Waterbury State Hospital.
I did.
But you've also worked in the prison system. And do you think there's more chance that if people with certain mental health issues in the community are not properly cared for, that they might end up in the correctional facility, or is there any correlation?
Oh, I think there is. I see a lot of people at the prison who I believe would not be there if it hadn't been for some kind of mental health issue. And so my job is, when they're there, to try to get them balanced out, so when they go back into the community, they're going to be okay and they're going to stay out. Unfortunately, we see the same people coming in all the time because they get balanced in corrections, they go back out, they can't afford their meds, they stop taking their meds, whatever it was, and then they come right back in. So
Now, how's the some people call it a drug epidemic.
Mm-hmm.
Do you ever get doctor shoppers, Dr. Lockridge? And to the viewers, a doctor shopper is a person who essentially goes around, they're trying to get prescription drugs, particularly painkillers. Do they ever show up at your door?
When we first opened, there was a little bit of that, but we really don't have that anymore. I think word got out relatively quickly that we were there to help people with medical problems and not just to refill prescriptions. So that's not much of an issue anymore.
there's a really neat tool that just came out of the legislature. It's called the Vermont Prescription Monitoring Service, and you can put someone's name in. I was doing this last night for some of my patients in the prison, and it shows all the different doctors they've gone to. It's really powerful. So that's, I think, going to curtail the problem.
Right, because I know I had one doctor, he blanked out the name of the person, showed me that one day he caught on to this person. In one day, how many places he'd gone around the state and managed to get prescriptions filled. This was before this computer monitoring occurred.
Or they go out of state, or...
Right. So what are when you look around, we obviously have some good practitioners in the area, but you'd say that we're understaffed, this area is?
Oh, yeah, just as he was saying about the waiting time to get in with someone. And if you're feeling suicidal or you're so depressed, you're so anxious, you can't wait 10 months to a year to see somebody. The program that I went to at UVM unfortunately closed, and so there's not a lot of people like doing what I do coming up through the ranks anymore. It's really hard to get someone.
I was talking to a person recently who was very honest about his mental health issues, and he was saying he called for help, and he was suicidal, and he was told, I'll be up in your area next week. He says, you won't need to come up next week. Well, why won't you? Why won't I? Because he said, I'll be dead. And they then got something into place. But he was telling me how, and he wasn't blaming the providers of the area, because, the providers can only do what they can do. Now, what happens, Dr. Lockridge, if somebody comes in to your office and they are suicidal, what do you do?
A suicidal patient belongs in the emergency department, and there they can be monitored the most intensely and have access to the most services. Also, they may have already made some form of attempt in the way of an overdose, and they can be tested for different toxins in their bloodstream. So that's the first thing. We'd want to get somebody to the emergency department. Then hopefully they can be evaluated by a psychiatry professional and triaged appropriately. That is part of the art of a psychiatrist, is being able to tell when someone says, I'm suicidal, are they really on the brink of some kind of disaster? Or is it somebody that maybe just needs something to get them over the hump for the day? And patients like that can often be discharged from the emergency department the same day that they come in. Patients in the other category, I think, usually are now transferred to another facility in the state, Brattleboro, in my experience, being the most common one.
Right.
And with the closure of the state hospital, and this has been all over the papers and the news, but people were waiting in the ER for days and days and days. You know, actively psychotic people, very suicidal people waiting for a bed. When with the closure of the state hospital, you know, that just compounded the problem. I was actually down in Berlin yesterday and I saw the new hospital. It's state of the art, so that's going to be opening up soon. I think it's 33 beds, and hopefully that will help the problem. But there's just not a lot of beds in general in Vermont.
Now, how does the state's drug problem, how does that play into the whole mental health issue?
You know, you had mentioned earlier that painkillers.
Right.
Well, for psychiatry, you know, there's a lot of people seeking stimulants, ADHD drugs, you know, benzodiazepines, and a lot of times people try to get those so they can buy the painkillers or the opiates, and it's just all interwoven, and it's really bad.
I've had the privilege, and I say it's a privilege, even though I feel bad for the people, is I have talked to people who have struggled with addiction, and I think both of them have largely beat it, but it's so interesting to sit down with them and talk to them, because for some reason a lot of us view the average drug user as being somebody we probably wouldn't associate with. I think we'd be surprised that we probably every day we interact with people who have drug problems, because it was interesting. And like one person was telling me, as you were saying about having people go to your office, is they know, like she was one of them was telling me how you knew which doctors to go to get what, and which doctors don't even try to get an aspirin from. And it's been really it was a fascinating thing just to. And then if you can't get prescription drugs, you then, some people resort to heroin and vice versa.
I don't think anyone wants to, you know, have a drug problem, or no one wants to be an alcoholic, but it happens.
Right.
And we were talking about, you know, people start off getting legitimate pain meds, and
well, the effect of the drugs is very powerful, and people get into serious trouble with them before they realize it. I think that someone who takes 3 or 4 Percocet every day for back pain for a couple of years doesn't think of themselves as an addict. But they will go through withdrawal, both physical and psychological, if their pain medications are taken away. And at some level they sense this, and they get profound anxiety if their painkiller supply is threatened. And it's, as you say, completely across all class lines, all walks of life. People in positions of real authority, educated people, people that work hard, people that are very respectable still get into trouble with these drugs, and they still are susceptible to the same problems associated with addiction.
So where did this all, particularly with prescription painkillers, it seems like it came out of nowhere in recent years, but I'm sure it did. Now, I think you and I talked before, Dr. Lockridge, about the older doctors. They weren't as trained because when they were going through med school, a lot of these drugs weren't on the market for them. But your generation of doctors, you're pretty educated on the dangers of these things.
That's right. In the second year of medical school, we have pharmacology classes, and those typically will really lay it out for you as far as the appropriate use of narcotic painkillers. And we were trained very rigidly that you are not to use narcotic painkillers to treat chronic pain, that you virtually guarantee addiction if you give a drug like that to a young person on a chronic basis. I think that previous generations of physicians were aware of the addictive potential, but maybe not quite the scale of it.
Right.
More than that, we also have, as you said, different preparations of drugs now that have fewer side effects than old-fashioned morphine, and so people are a little bit more likely to take them in excess and to get into trouble with them.
There was also, when I served in legislature, we also heard testimony to that there was a period of time that medicine, as in the medical establishment, viewed painkillers as a way to keep healthcare costs down. Because instead of going through surgeries, you could prevent people going through surgeries by giving them painkillers. So there was actually a concerted effort to prescribe these to people who might otherwise need.
Wow, that sounds like Big Pharma was intervening. I mean, I think that's another issue is the drug companies, in my opinion, are running the country, basically.
Yeah, you see these on TV.
Yeah, there's a lot of money involved, and
Right.
drugs have become, look at the commercials on TV. Are you feeling down or blue? Here, take this medication and life will be great again. They're the ones that are driving a lot of this.
Yeah, because, and then you must be bombarded by, or at least get a fair number of people who are they're not drug seekers. They're good people who might have some mental health issues who every time they hear an ailment, they think they have it. Because, even if I went to the computer and did a little Google search, I could probably convince myself that I have typhoid fever or something,
Oh, I thought you were going to reveal your psychiatric illness.
Yeah, I know.
That
I was ready
we've
to
all
help.
been aware of for years. You're among friends.
I mean, that's like people come in and they say, I think I'm bipolar, because my moods change. And I've worked with some really, really ill people who are really, truly bipolar. And I just try to help people say, well, I think the problem is you're human, and that, like all of us, our moods change, and you're going to have good days, and you're going to have bad days. And if you're having a bad day, that doesn't necessarily mean you need to get on drugs,
Now, talk about drugs. I think one of the questions you've already been asked is, are you prescribing like Suboxone for prescription drug addiction?
No, I'm not.
So if somebody, but you will treat people who have drug addiction, but not with drugs.
Not specifically. That's not my specialty, and
Right.
so I would refer someone like that to someone who is a licensed drug and alcohol counselor, who couldn't really help them. I mean, I may have a patient who has drug issues,
Right,
but
a secondary issue or something.
yeah.
So
But
what is it? What are you going to be? What is your typical day like?
there hasn't been a typical one. Ask me in a year. I get
I don't think there'll be a typical day given 25 years.
Yeah, okay. A lot of anxiety, a lot of depression. A lot of times that's caused by substance abuse. So it's teasing out what's really going on. There's bipolar, there's schizophrenia, there's all sorts of diagnoses, and I never know. And someone comes to you with a record,
Right.
well, and people say, I'm depressed, I'm anxious, I'm bipolar, and it's kind of, well, are you really? Because you got that label by
Right.
someone who'd met you for 10 minutes 5 years ago. And so what I like about working with Dr. Lockridge is I'm getting this time to really talk to people and get to see what's going on and go into the histories and really tease out what the underlying issue is.
Right. Now, how did this relationship come about? Because to me, it looks like a great idea because, you think of health. Well, physical health. Well, there is the mental health component, and it just seems like such a logical idea to have the two of you teaming up together. Well, we know how you met there, but what were you thinking when
It was completely driven by need, and I'm sure any primary care provider in this community sitting in this chair would tell you exactly the same thing, that we are underserved for psychiatry services. And what I saw in corrections was that they got outstanding psychiatric care. And I thought we probably shouldn't have to commit a felony to get good health care in the Northeast Kingdom. And more than that, just practically speaking, as I acquired more and more primary care patients, the need was there for me personally as a practitioner. I had to get these people taken care of. And like I alluded to, just about every primary care provider does some psychiatry, just by necessity. And when you throw in the oncology, there certainly is a lot of anxiety and depression issues that you have to get comfortable dealing with. But beyond that, the issues were beyond my experience, beyond my knowledge. I have complete knowledge of the drugs and their interactions, their safety profiles, and this sort of thing, but there's a lot more to psychiatry than just writing a random prescription. And my patients needed that. The patients in the community that weren't mine needed that.
Yeah, because that's the other thing is your services, to have your services, you don't have to be his patient. If you...
Mm-hmm.
No, we're separate practitioners.
Right.
A lot of her patients are shared, but she has a lot of patients from other providers as well.
So you've had other
Yeah.
patients?
Yep.
Well, that's good, because I really do think we need it. I was telling you, at some point, you should sit down with George Coulter of Newport. George was one of the pioneers of the of Northeast Kingdom mental health back in the 60s, and he will tell you when they arrived here in the 1960s, it was a very interesting place to be a psychiatric practitioner. Probably even more interested than today in some ways.
I heard stories like that directly from my friend Jim Irwin before he passed, and
Yeah, they came here together.
that's right. Yeah, and he always spoke very highly of George, and Jim was a great man. He did great things for the area.
Yeah, that whole group did. They really did. Okay, another issue that's actually making the news quite a bit, especially with the troops that returned home, is PTSD. I hope I got the initials right.
Perfect, yes.
But explain to the viewers a little bit about this disorder.
Well, post-traumatic stress disorder is, as you had mentioned, it's growing, and I always wonder if it's always been there, and we just know what it is now, how to recognize it. I mean, certainly with veterans coming back, you see it, but it can happen to anybody, and I think of it as something very traumatic happens to you. And remember records, they'd get a scratch on them and the needle would keep sticking on that one groove. That's kind of what happens to your brain, so you can't let it go, whatever the traumatic event was, whether it's, you were in a battle or you were abused or you saw something horrible happen. So your mind just keeps coming back to that. And some of the symptoms you see are people being really hypervigilant, horrible nightmares, people startling easy, people acting in ways they didn't used to act violently. You know, there's stories of people going off to the war and coming back and their wives saying, "Who are you?"
Well, I have a bit of a view into this disorder because I've interviewed so many World War II veterans, and there's, you know, because we have people, you know, PTSD is very well known today, but back then, if you were a World War II veteran, you were a man, not always, but when you arrived home, you were supposed to, as a man back in that generation, you were supposed to suck it up. You were to come back, and suddenly, you know, when you returned home, everybody thought you were going to be that same person. And like, I've talked to wives too who basically said that when they came home, if they tried to talk about it, we'd say, "Oh, no, don't bring that up. That'll bother you." And World War II veterans today, the surviving ones, they're very open now, you know, 'cause they find this generation of servicemen, it's very liberating where they can talk about their feelings, whereas, you know, their generation, you just couldn't talk about it, and they believe that talking is actually part of the key to coming to grips. Do you agree with that?
Yeah, I mean, there's different therapies that are gold standard for dealing with that, and there's, you know, medication as well. But a combination of the two, I think, is the best. But I get a lot of vets in the prison system who, prior to going off to serve, had never been in jail a day in their life, and then something, you know, there's a lot of self-medication too when people come back because they're just trying to numb out that pain and horror, you know, and not just vets, but everybody who's.
Well, I think you know, whether it's, you know, maybe killing somebody in an accident or killing somebody at war, even in war where somebody's trying to kill you, it's still such a foreign thing, you know, that we're taught you don't kill. But so when you go off to war, in talking to veterans, it's such a hard thing to reconcile.
And I'm just going to use the example of people who had maybe as children something traumatic, whether they were abused or witnessed a death. I mean, that can just lay for years and years and years and be causing negative behaviors. And then I work with a lot of people, we're just starting to bring that out and look at that. You know, people have just shut it off, and so that's another example.
So what is, you know, so if somebody, you know, say in the legal system, in the correctional facilities, if they're able to work through these things, because, you know, it's a fact that once you get into the correctional system, the recidivism rate isn't, you know, you're going to probably end up back there. But if you come to grips with some of these issues, do you think you're less likely to end up back in trouble?
Oh yeah, definitely. I mean, I think we're driven so often by things we're not aware of that are in our subconscious, or things we've buried, or traumatic events, and that propels us through life, and we make poor choices. And so if you bring that out and start looking at it and see how it's been impacting your life negatively, that's when change happens.
Right. And so has this been a good working relationship so far, Dr. Lockridge?
Well, she hasn't had her semi-annual review yet, so I don't want to give away any surprises. But no, it's been great. I
No
think.
fights so far.
So
anything?
you've
No, we've got a very similar philosophy where it comes to therapy and approach. And we talk about every patient that she sees, and so far we're in 100% concordance, and it's very harmonious.
So you've become quite a clinic, though, because you started off, I think, a well-known oncologist, and that is still a very important component of your
It's still our
practice.
focus.
And but then you've taken over with adult medicine, then you've joined the practice, and so what's your next?
Well, I can't commit to anything just yet. You know, we want to do things deliberately. You don't want to bite off more than you can chew. You don't want to start in on expansion into completely foreign areas when you don't know whether what you're currently doing is working. But like I said, we're need driven, and there are a lot of needs in the community, and we are observing that, we are taking that to heart, and we're going to do the best that we can in the future to meet those needs.
You know, one need seems to be, but nobody seems to want to really tackle it, is a walk-in clinic. You know, because for a long time we had.
There was an urgent care center.
Yeah, but you know, in recent years we haven't had that. The closest to a walk-in clinic is the ER, and you know, that's a bit expensive.
It's true. It's the least economic way to deliver health care, and eventually that's going to be looked at and discouraged in an active way. I believe that at some point the patients are going to bear the burden of that expense. It's essentially unavoidable. I would really like to have an urgent care center to refer people to so they wouldn't have to go through the complications of the emergency department. But it's very complicated. It's because of the hematology and oncology aspect of my practice, it's essentially impossible for us to do, because we have to have set appointments for these people that cannot be missed, are never missed. Our no-show rate is very, very low. So you can't depend on any open spots, and the spots that are full are absolute necessity. And we have to leave some degree of flexibility to treat the hematology and oncology patients on an urgent basis if some kind of issue arises, or the internal medicine patients if it's a serious issue. So urgent care is not going to be feasible for me personally. I'm not saying never for the clinic. We could potentially have practitioners available for that kind of thing, but for me personally, it's not an option. It's a really, really complicated thing to pull off.
And because your practice is located on Union Street, you're close to the hospital too, and I think that's a good working relationship there.
It's a great location. We're extremely lucky, and we owe an awful lot to the Julians.
Dr. Julian.
Dr. Paul Julian, the ENT surgeon, and his wife, Francoise, who's his nurse. We owe them quite a lot for taking us in, for teaching us certain aspects of the business, and providing such a good location for us. We are right across the street, literally, from the Newport Ambulance Service. That's very important for oncology patients getting therapy. One could certainly argue that that's a better positioned area for oncology patients than even certain departments in the hospital.
Right. Hey, here's a little trivia. Since I like to throw in trivia, historical trivia. Okay, you mentioned the Newport Ambulance. Did you realize back in the old days, especially up here, the ambulance doubled as a hearse? They ran. It was the Curtis Funeral Home and Ambulance Service, or vice versa, and so there's a little bit about
I didn't know that.
Yeah, historic trivia.
Thank you.
Yeah, that's fascinating.
So you know, no matter how things end up, they had their business.
Yeah, that's you don't know how to feel about seeing the ambulance / hearse coming.
All right, we only have a few more minutes left. What more we'll direct it back to you, Catherine. What more would you like to say about the services that you are going to provide to the people of the area?
Well, my philosophy's always been, I think there's a lot of overprescribing in the community. I think there's a lot of, you know, this pill is going to change your life, this pill's the answer. That being said, medication can really help people. During certain times of their lives, some people need to be on them all their lives. I try to work with people to, if necessary, get them on the right medication that's not going to have a lot of side effects that they will continue to take. A lot of these meds have horrific side effects. You know, you're going to gain 100 pounds and you won't want to have sex, but you'll be fine. And if necessary, take people off the ones that could be harming them. I mean, sometimes you'll get on a pill and then you need another pill because you're having side effects from that pill. I mean, you see it all the time. And so people come to you and they're on 20 different meds, and I'm not kidding. And so it's just, I really like to see what it is that's working, what's not, and if a pill's not the answer, I really like to work with someone, and behavior changes, diet changes, are you exercising, are you walking every day? Just little things like that can really make a difference.
One frustration I hear from my doctor friends, not Dr. Lockridge, but is, especially if you're a doctor and you work underneath somebody or an institution, is sometimes they feel so pressured to get the patient in and out that they no longer feel like they can do good health care anymore. And I think sometimes maybe that's where the pill thing comes in. But whereas I happen to go to, I think he's the god of doctors, Dr. Robert Wood of Derby, and time is not important to him. Good healthcare is, and I'm already mortified that he has his clock ticking like 2.5 years left, and because I know you envision yourself an outstanding doctor, Dr. Lockridge, but I think you will agree that Dr. Wood is.
Well, Bob Wood is my doctor also, so there's two of us that are going to have to find new physicians in a couple of years.
Yeah, but you can't go to yourself?
No, that's not really a good idea. Yeah, the lawyer that represents himself has a fool for a client. It's the same thing with physicians. You really need outside eyes looking at you objectively.
And another thing about doctors is, and especially I think the older generations, is because of our, growing doctor shortage here, people hate to be juggled between practitioners, because I don't care so much, but I think like my mother who passed away last year, although I believe she got questionable care, she would have been she was mortified whenever she would go to the doctor and she would get somebody else. And I think the consistency of care is very important.
Mm-hmm.
Well, for sure.
So if they go to see you, Dr. Lockridge, who are they going to see?
Well, they only have one choice. I'm sorry. I'm the only me that I can offer. So every patient that's scheduled in my clinic sees me.
Right. Okay, final words. I'll go with you.
Well, we're very happy to have Catherine aboard, and we're very excited for what it's going to do for our clinic and for our community. Going forward, certainly we want to benefit the community as best we can. Anything that is practical for us to do, we're going to do. And if you have any questions, any reservations, any confusion, just give our office a call. Danielle or Carlene will be happy to talk to you about exactly what we offer.
Right. Final words.
Well, I guess I'm so grateful to be working with Dr. Lockridge and his wonderful staff, Danielle and Carlene. There was so much. I didn't just walk in one day and it was 6 months of paperwork, I think. It's getting on the insurance panels, and Danielle helped me so much with that. It's just a real luxury because I get to sit with these people and spend the time with them. And that is rare. I mean, in the community, it's boom, boom.
Right.
And so it's a luxury to be able to do it, and I really enjoy it.
And although you are not a native to the area, you are married into a very well-known family, the Roden family, who some of the older viewers might remember as the top dog of the game wardens, Scott Roden.
Yeah.
And you're married to his son.
Tom, yeah, and his sister was also a game warden.
Oh, really?
Yeah.
All right. Well, thank you for coming on. I really look forward to what you can do for our community because this isn't just about Dr. Lockridge's practice. This really is about the community and its people. Thank you.
Thank you
thank
very
for
much.
having us.
And thank you to the viewers for tuning in to another segment of the Northeast Kingdom Voice.